of the best of the aortic presentations coming from North America, which proudly will be presenting 3 activities that we're leading from Memorial, but at the same time, I would say co-leading with our colleagues from Africa. And with this said, we're going to be talking about 15 minutes about the new study that Dr. Ndlovu from Zimbabwe, myself, and many others are part of for HCC in patients living with HIV. After those 15 minutes, we'll pass it on to Dr. Precious Makonde. Many of us know Dr. Makonde. Precious from Malawi will be talking about the impact of the microenvironment for the liver cancer and how we can learn better about how to enhance it in the setting of immunotherapy. And lastly, we'll be joined by Dr. Ashraf Omar from Egypt, who will tell us about the new guidelines that we are revising, and hopefully you all will part of one way or the other, and we hopefully will be reporting again at the Aortic, as well as hopefully have them published. This is something that, as you remember, we also presented at Aortic back in Tunisia last November. So with this said, without further ado, I'll pass it on to Dr. Ndlovu. And to cause applause, probably, please, the floor is yours. Thank you.
Thank you very much, Kassan, and greetings to all the participants from all the various regions of the world. I will start my presentation. I think I've already been introduced, and that's me over there. I'll have to switch off my video, unfortunately, due to the bandwidth issues. I may have to switch off my video, but let's see how it goes. Okay, so I'm going to be presenting to us on this HCC study. So I'll start off by disclosures. I have no research disclosures to make. I have no consulting disclosures. So this whole study, the rationale was based on that hepatocellular is a global and African problem, but more so to do with Africa. This slide from Young JD et al. Shows us that, you know, if we just go right to the bottom of the graph, we actually see that Africa as a whole, you know, has got the poorest survival time from treatment initiation. And this is Egypt, which is also in Africa, which is slightly better than the whole of Africa. But we can see a sharp contrast between places like Taiwan and Japan, which are leading, but with North America, countries like North America and South Korea following very closely behind these other 2 leading countries. So what is this study all about? It is about the use of electromagnetic fields to treat hepatocellular carcinoma, and it's particularly attractive to Africa because it's one device and it's not invasive. So it can actually be safely used on patients like what we see in Africa who come with generally advanced disease that is beyond surgical intervention. So what does this entail? Is a 4-step procedure whereby, first of all, there is determination of the baseline hemodynamic variability of that particular individual. And then after that, then there is exposure to the electromagnetic frequencies, and followed by the data processing from this to a modified hemodynamic variability that corresponds to that of the patient, and then the identification of the therapeutic frequencies that should be used on that individual patient. So as you can see, this is the GEM is actually a trademark for this device that is produced by AORTIC. So this is an illustration of what happens when gem is applied to hepatocellular carcinoma. Our slide A here is showing us, a typical H&E stain of hepatocellular carcinoma. And slide B here is showing us the evacuation of the cells, and basically they are disintegrating after the 3 hours after the use of gem. And C and D are now higher magnification times 40 for the same cell, and it actually shows us the changes where this is the cell before the treatment, and now you can actually see the evacuation of the cell, the disintegration of the nucleus and the mitochondria, which actually is a pathological verification that this treatment is actually effective. And this is again a response to the hepatocellular carcinoma following gem treatment. As you can see, this patient has been treated for approximately 2 years on gem, and this is how the original tumor. And then post-treatment now, you can actually see that there's really very little tumor remaining there, with mostly, cavitation in its place. And similarly, for the lung metastases here that you see illustrated here, they have really, you can barely appreciate them after this treatment. Sorry, I'm trying to advance my slide here, and I'm not sure if I can. Don't know what's okay. Yeah, there we go. Sorry about that. And so this is a study that was done by Costa F. et al. In South America and was published on the 15th of May, 2023, which is actually showing the response to the GEM treatment using RACIS 1.1 criteria. And we can actually see that with monotherapy, we are actually having quite good response, with complete responses even, and disease control rate, it's 72%. And there was actually one patient in the group who actually received a complete resection, had a resection post-treatment and remained cancer-free. So with combination therapy, there is some improvement in the disease control rate with an overall of 76%. So this was actually quite a good results, as was seen in this particular study. So now we go on to the actual study, the study schema of the GEM-CC study. So patients with advanced hepatocellular carcinoma will be recruited, and the child per score A or B, performance status 0 to 2, to be done at, initially it was planned to be done at AMC core sites in Africa, but that may change. And then stratification factors here would be the line of therapy. In other words, are they treatment naive? How many therapies have they had? So 1 versus more than 1, and CD4 count 480, whether it's below or above 480 as a cutoff point. And also the child per score is going to be used for stratification as well as the viral versus the non-viral etiology. And then so these patients will be randomized into 2 groups, one where the gem is going to be applied for 90 minutes every 14 days, with exposures being done approximately 3 days apart, and then a sham where the same will be done. The only difference here is that the machine that we're going to use for the gem and the SHAMU are really identical, except that the other one will not be producing the electromagnetic frequencies. So then radiologic and clinical evaluation will be done after every 4 treatments and or every 2 months. So the study objectives are the primary objective being the overall survival at 1 year follow-up post-treatment. Secondary objectives will be progression-free survival, time to progression, and the objective response rate. Safety and tolerability will also be assessed, and some correlative studies will be done relating to the CD4 count, viral load, next generation sequencing of HIV related, HIV associated hepatocellular carcinoma, and then the genomics of HCC biology and HCC in patients living with HIV will also be done. So these were the assumptions and statistical considerations that the median overall survival for the GEM will be 6.7 months, and that of the sham will be 2.5 months, making us get to a sample size of 46 patients, 23 patients on each arm, and giving us a hazard ratio of 0.375. So the key inclusion criteria for these patients is patient living with HIV on standard HIV treatment and screening as defined according to AMC protocols. They must have confirmed diagnosis by histology, and the tumor must be deemed unresectable. Any number of prior therapies will be permissible, and we have already stated about the cirrhotic status and the performance status, and they must have fully recovered from any prior surgery or local treatment, whatever, like embolization or whatever else is done at that particular center. But none of these treatments should be within the 2 weeks of initiation of therapy. So the key exclusion criteria are really basically the standard for most clinical trials of this nature. So we're considering cardiac disease, infections, intercurrent illnesses, psychiatric illness that would limit compliance to the study, and the anti-cancer within 2 weeks has been mentioned, and so any other primary cancer, with the exception of curatively resected melanoma skin cancer or curatively treated cervical carcinoma in situ, and any other solid primary tumor with no known active disease at the time of recruitment. Now it's just a run down of the correlative of the other things that are going to be considered. So most of these are the exploratory objectives will be done under the auspices of Memorial Sloan Kettering Cancer Center, and the names there are the persons who will be responsible for that. So for the CD4 counts, CD8 counts, viral load, basic metabolic panel and liver function test, where we will be requiring blood at baseline, those fall into their own group, and then it's the diagnostic tests are like is stated there: mutational analysis and mutational load, RNA sequencing, and immunohistochemistry will be done on the biopsies and bloods at baseline, with Michael Berger being responsible, and the imaging correlative studies using, probably here is written as RECIST 1.1, and MRACs, these could change depending on when the studies become active. So the patients will have CT scan, thorax, abdomen, and pelvis, 3 to 4 phase liver scan at baseline and at assessment times. So these ones will be done by Victoria Paroda at MSK. And in Africa, this study so far has been considered at all the 5 active AMC sites in Africa: Kenya, Malawi, South Africa, Uganda, and Zimbabwe. And the anticipated accrual is quite promising. This is per year. So in total, we have about a potential of recruiting 45 patients per year. And I think that's the end of my presentation. Thank you very much.
Thank you very much, Dr. Kovu. Kozo, this is great. Thanks so much again for your presentation. I would like to hear to quote the important part. Please don't undermine how important this is, what Nkozo is actually telling us about. Nkozo and Precious and many other colleagues, you saw some of the names on the presentation. We've been working all together on this since 2014. This is like already 12 years in the making. And if anything, where we are today, proudly, we crossed through all the important committees of the NCI, and we are at the last committee. We have one small hiccup, which is important for us to know, that the study is only pending one review from the final committee. However, because of change in strategy, we might have to expand that study and start it in the United States and then expand to Africa later on. We're working on it, but stay tuned. What's our idea why the study is specific? Because number one, as we all know, patients living with HIV and HCC don't have a standard care therapy. And number two is to provide therapy in the form of pills or intravenous, because of the resources and limitations, can be a challenge. That's why the electromagnetic wave frequency, which is a robust science as well, came into play. But with this, I will pass it on and we'll hold on the questions till the end, but I'll pass it on next to Dr. Precious McCondy. Precious McCondy, many of you know, a really great and superb colleague and physician whom I'm really proud and honored to have actually mentored over the years. And he was one of the winners of the IDEA award from ASCO, and he actually spent time here at Memorial Sloan Kettering. And since then, we never stopped working together. And Precious, the floor is yours. Please tell us all about the immune microenvironment. I think we don't hear you. If you put your unmute, would be great. Thanks.
Greetings. My slide are being shared.
Yes, they are, but would like to change it to presentation mode so we can. Perfect. Thank you. Thank you, Precious.
All right. Okay. Thank you. So greetings once again. As Professor Gasana said, my name is Precious Takondo Makondi, medical oncologist from Malawi, specifically Kamu Central Hospital, the National Cancer Center. Thank you, AORTIC and Memorial Sloan, for giving us this platform. So I'll present the second study we are doing in collaboration with Memorial Sloan, where we are trying to understand the tumor immune microenvironment in hepatocellular carcinoma. I have nothing to disclose. So hepatocellular carcinoma grows in a microenvironment comprising of cancer cells, immune cells, like the T cells, blood vessels, fibroblasts, signaling molecules like cytokines or VEGF. So this microenvironment may be defined as a hot or cold. When we say a hot microenvironment, we mean that one which is full of inflammatory cells, and there are specifically T cells inside the tumor. This is the example in hepatocellular carcinoma, may be the viral-related hepatocellular carcinoma, while the cold microenvironment is the one where there are actually few of these inflammatory signals or the T cells, and generally the immune system is suppressed. So pertaining the hepatocellular carcinoma is said to be generally cold, a cold tumor, where the immune system is suppressed mainly in 3 points. Mainly, first in the lymph nodes, where it's suppressed, or activation and priming of T cells is suppressed mainly by checkpoint signals of PD-1 or CDLA. And also in the blood vessels, where abnormal VEGF signals and also abnormal vessels block the physical entry of the T cells into the cells. And also in the microenvironment itself, where there's general immunosuppression, which is driven by the inhibitory signals of TGF beta and other signals. So understanding these pathways and barriers is what led to the discovery of the novel immune therapies which are used in hepatocellular carcinoma. For example, the first study to break through using this mechanism was the IMBRAVE 150, which used atezolizumab and the anti-VEGF bevacizumab and compared it with sorafenib. In this phase 3 study, they noticed that there was 42% reduction in the risk of death. Although the median survival was not yet reached versus the 13.2 in the sorafenib arm, this study broke into the standard of care, as it had a 6 months overall survival reduction of 84.8 survival rate versus the 72.2 in the sorafenib arm. The other study, which was also one of the landmark, is the Himalayas clinical trial, which used the STRIDE regimen of tremelimumab at 300 milligram plus durvalumab. This was a dual immunotherapy blockade and compared to sorafenib, and it achieved the median overall survival of 16.4 versus the 13.8. So the tremelimumab, which is anti-CTLA-4, led to the priming of the T cells, and this led to durable cells, and also this regimen is better and beneficial to those who are at risk of bleeding, like those with liver cirrhosis or the varices, and also it reduces the need for doing upper GI endoscopy as it is with the IMBRAVE study. The other study which achieved the highest first-line median overall survival was the KARES 310, which achieved the median overall survival of 22.1 versus the 15.2 in the control. This study used the camrelizumab and the VEGF tyrosine kinase inhibitor rivoceranib versus sorafenib. So these studies are done in a clinical trial setup where the audience, the patients are in a control with a lot of control, and the inclusion and and exclusion criteria. So the AB really wanted to see if the clinical trials can be translated in the real world. So it compared the trial benefits of the I am Brave versus the
We lost your presentation mode. Maybe you should go back to it. Thank you, Dr. Makondi.
Okay. So the ABRU study wanted to understand if the real world setup can be compared to the clinical trial setting. So they compared the clinical trial findings of IM Brave 150 versus the real world findings. This study was able, although the overall survival was lower at 15.74 versus the IM Brave of 19.2, this study showed that the trial findings can be translated to the real-world setting by demonstrating that the progress-free survival was comparable at 1:1 at 6.91 months versus the trial of 6.91. Yeah, so this study concluded that the trial benefits can be reproduced in a selected clinical practice. So Fister and colleagues wanted to understand what really matters, what really lead to the treatment response. So the team explored the findings of the 3 clinical trials versus the response, and in pertaining to the etiology of the related to the hepatocellular carcinomas. The study they look into the Checkmate 459, the IMBRAVE 150, and the Keynote 240 studies. What they found was that the viral-related hepatocellular, not leaning to either hepatitis B or C, showed the biggest benefit from immune therapy compared to the non-viral caused hepatocellular carcinoma. So the mechanism can be explained that the hepatitis B related hepatocellular carcinoma create a chronic inflammation, therefore creating a hot tumor microenvironment, which is likely susceptible to the immune therapies. But when we go to our landmark studies, the IMBRAVE Himalaya and the KS 850, we noted that the studies were not comparing in key aspects. The studies had different patients and also different biology. For example, the KS 310, the majority of the patients at 83% were from the Asian region, and also 76% of these patients had hepatitis B related hepatocellular carcinoma. This is in quite contrast to the Himalaya study, which had 41% of its patients who had non-viral related hepatocellular carcinoma. So we could see that the results of the KRAS 310, which had a highest first-line response from the immune therapy, were heavily affected by the patient profile and also the patient profile and also the region from the patient. And this affected the treatment response and the disease kinetics. And another study we want to explore is the Checkmate 9DW, which used the nivolumab and ipilimumab. This is also a dual immune therapy blockage, and they used that they compared against the standard of care, which was the lenvatinib or the sorafenib. This study achieved the median overall survival of 23.7 versus 20.6 in the control. You can see that in the Kaplan-Meier curve, there was an early crossover. This translated not to failure in the treatment, but as you check with the anti-CTLA4 require a priming, which is slow, and this lead to the early crossover. And also this study led to a 2-year sustained overall survival at 49%. So why was this study important? If we check in the geography, this study had a balanced population, 40% Asian, 43% Western, and it was across 23 countries. And when we also looked at the etiology, it was 34% hepatitis B, 27% hepatitis C, and 37% had non-viral related hepatocellular carcinoma, which translates to a near 1:1 split. And also in the control study, importantly, they used levantinib, not sorafenib. Levantinib is the modern standard now. So let's look to the concern of our study, which is the patient biology. And also if we can try to find biomarkers which can translate to the good response from these clinical trials. An example is from the Kelly and colleague. They used the Himalaya study and the drug that were used there. So they used the 4 arms. The first arm, they treated the patient using the stride regimen of 300 tremelimumab and durvalumab. And the second one, they used the lower dose of tremelimumab of 75 milligram and durvalumab, and then the single agents of tremelimumab at 3 milligram and durvalumab. And they compare this to the expansion of the T cells of CD4 and CD8. It was shown in their observation that the single dose of 300 milligram tremelimumab had expansion, a biggest expansion of CD4 and CD8 T cells, while the lower dose of 75 milligram failed to replicate this. So the explanation is that the priming dose or a shock of the CTLA checkpoint drug resulted in more helper cells in the lymph nodes, leading to better priming. And also this one lead to the blockage of the hepatic resistance. Okay, in other sense, like turning the cold hepatic microenvironment into a hot one. And also diving deep into this, they observed the absolute cell count, mainly the proliferative cells, which included the KI67 on day 15 against the treatment. It was noted that the stride regimen led to highest number of the proliferating cells on day 15. Going deep, diving deep and relating this to the treatment response, it was noted that the increased number of the proliferative cells was related to the treatment response. It means that those who responded well were the ones who had high numbers of the proliferative cells and also the T cell counts, specifically CD8 counts, while non-responders had a few number of these proliferative cells. So this translates to the stride study had the highest proliferative number of cells on day 15 as compared to other 3 doses, the single agents and the lower dose tremelimumab, suggesting that the tumor microenvironment really may play a role in hepatocellular carcinoma progression and also treatment response. Therefore, how can we try to translate this and understand the tumor biology in relation to African setting? So the rationale is that the current gap is that most hepatocellular carcinoma trials are done outside Africa, US, Europe, Asian. And this study led by the Memorial Sloan Kettering want to map hepatocellular tumor immune microenvironment in relation to heterology and ethnicity. And this will include Africa in countries Tunisia, Ethiopia, Malawi, and Egypt. And we want to see and quantify the baseline expression profile of PD-L1, CD8, CD3, PD1, CTLA4, and LAG3 in the tumors from the African people of African ancestry. So what's the benefit of this study? This study fit to the global need where we need regional data, where we can choose and select patients, importantly, who can benefit from immune therapies, whether they have a viral-related disease or non-viral-related disease. So putting this all into context, these results have clearly demonstrated that hepatocellular carcinoma is a cancer which is heavily relied or driven by the tumor microenvironment. And altering or tackling this microenvironment may lead to discovery of personalized or treatments which are really beneficial to our environment. So the three important steps matters: the etiology. Our population is heavily infected with hepatitis B, leading to the hot tumor microenvironment, which may be beneficial to PD1 or CTL4 molecules. And also we need to explore the access. The bevacizumab now is commonly available, and also the TKIs may be available. So we need to also explore these biomarkers which can lead to the sensitivities to these molecules. And the third one is the activation matters. We have seen the demonstrable effect of priming with CTLA4, and it has shown to give durable tails. So that's all from this study, from this presentation, where we want to explore tumor immune microenvironment to find targetable biomarkers which can lead to better response for hepatocellular carcinoma, mainly in the African settings, and also to have our data which can be compared to other studies and also other settings. Thank you.
Thanks so much. Yeah, of course. Thanks so much, Dr. Makondi. Precious, as you noticed, I let you go because, to be honest with you, this is a very, very important study. Probably the first time ever Africa will look into the immune microenvironment for liver cancer, and we're very delighted to see that. So again, thank you. I know a little bit tight on a little bit of time. Don't worry, we have plenty. Sadly, Dr. Ashraf Omar just texted me as we speak, and I asked him, and it seems that he had to rush his mother to the hospital in Cairo, and she's critically ill. So for that, no worries. We, of course, wish and pray for her that she'll be in good health. But at the same time, I'm going to go ahead and share what Dr. Omar was supposed to present, and then we'll still have time for questions. So if you bear with me, I'll share my screen. Maybe if, let's see, perfect. Okay, thank you for that. And so many of you know that study more than the other two as well, because this is work that we kind of like, we've been proudly doing all together. And I'm here again presenting on behalf of Dr. Ashraf Omar and all of the other co-authors and these are his disclosures. Mine also are with aortic. And if you recall, our argument was that we really didn't know which guidelines for treatment of liver cancer are the right one for Africa. And if you recall, back in 2021, we started the program, and we proudly had a committee that looked into which guideline will be best for us. As you see, Africa works in different ways. It's a big continent. We have a lot of different perspectives. And for example, and this is one that really we have a lot of weight on, NCCN guidelines that erroneously people think is going to be presented or used in Africa. Everybody uses them. Only 30% of us in Africa use them. So clearly, this required some further evaluation. For that reason, proudly, we have this committee that I'm really delighted and be part of, along with all colleagues from throughout Africa. And as you see, some of you might see even your picture over here. We actually, if you recall, back in 2022, we had a meeting and we collected information from the doctors about how do they care for patients with liver cancer in Africa. And proudly, we were able to collect information from 500 physicians from throughout the continent. And that data already is published.
Are you on slideshow?
Yeah, you're not seeing my slides?
We're seeing the current and the next at the same time.
Oh, let me see. Forgive me about that. Give me 1 second. Thanks much, because give me 1 second. Display setting, swap, presenter view, and slide view. Is that better? No? Hold on, let's see.
It's better now. It's better.
Okay, good. Sorry about that, everybody. So anyway, proudly we have this paper. Many of you have your name on. This was published in JCO Global Oncology, and in it we looked in the first time to the guidelines for treatment of liver cancer. What we really at that time, however, were a little bit challenged with is that we kind of, number one, the data was awakening, but the data required a little bit more thorough analysis because we want to make sure we get access to everybody. Number one, and very importantly, proudly, Africa does better than we think in regard to vaccination and prevention. For example, the access to hepatitis B vaccine is 70% in all throughout the continent. On the other hand, treatment to hepatitis B also about like 60+%, maybe a little bit shorter, the hepatitis C, which to be fair is only a limited challenge that we have mainly in Egypt. On the other hand, in regard to the treatments and diagnostics, they very much differed quite a bit, but however, the confirmation of diagnosis was a little bit in different places, and limited number of us in Africa did biopsies, only about 20%. In regard to early stage disease, Africa does rather very well in regard to resection. Understandably, transplants are a bit limited mainly to South Africa, to Egypt, and somehow certain extent in Nigeria. As far as, however, the other accesses to therapy are present, interestingly though, about 10% plus still have access to alcohol injection, which, as you know, is kind of like less favored at the moment in the Western Hemisphere. In regard to intermediate stage, proudly and impressively, chemotherapy embolization is heavily used in Africa. As you can see here, like up to even 70% in some locations, which is good. It means that we have this access, which of course, like for example, with the advent of the Emerald 3 study, we know what that means, that we have more potential access therapy for that. And when it comes to the advanced stage disease, on one hand, we're happy that, for example, sorafenib is readily accessible, as you can see, about 80% or up to 80%. But sadly, when it comes to immunotherapy, and at that time we did the first study, only atezolizumab plus bevacizumab was available, and only barely 7% had access to the immunotherapy. That's a big challenge we have. And for that, with those kind of advances that we proudly have presented at AORTIC, as I mentioned, we were reached out, and this is the proud things that we all have, we were reached out to by Microsoft that wanted to redo the study on their own platform to really give a better chance to better understand and especially look into rural areas and look also in palliative approaches or alternative therapy. For that reason, this is the aim of the study number 2. And in this one, we're looking about the same thing, but this collaboration with Sloan Kettering, Microsoft, and AstraZeneca. And the survey will be done twice. at startup, which, if you remember, we proudly launched that in Kenya, in Mombasa back in February 2025. And we are now up to 6 months more. We presented the rest of the data in Tunisia at AORTIC. And now we're coming to part number 2. This is what I can tell you where we are. And frankly, we're even doing better than that. So this is the survey at the moment. We have actually now the number is showing here 342 responders. We have 390. And this is in part number 1. And number 2, it says 245 is again 370. So we are close to about 700 plus physicians throughout Africa, thanks to all of you to be part of. And if anything, we're a little bit only concerned about the following. The numbers really are different quite a bit. Sadly, for example, we know Nigeria has a lot of presence regard to the disease, is now number 3. Interestingly, even sadly, Egypt is number 2. And the first one is Algeria. And one might wonder why. Because remember, this study is really representative by our eagerness and readiness to do this study rather than by how common the disease is. I know Dr. Omar in Egypt is working very hard on this. I know Dr. Sharif Falonso in Nigeria is working very hard to try to access more. But please, please, I urge you, I'm going to show you the QR code. Please take a picture of this. And this you can share it with other colleagues as well. But this will give you directly access to the study, which is IRB approved at Sloan Kettering. Automatically, by clicking on, you'll approve and you'll assure you that all your data will be private, and it will go through some of the questions that are related to the demographic elements, and this is all private, as I said, based on the IRB study. And at the same time, you'll answer a question about what's the access of care that you have. Now, question why we're doing this? Because proudly, we have to say that since we did this study, and as we presented, some of you were at AORTIC in Tunisia, we saw that the improvement in regard to access to immunotherapy has jumped on from 7.5% to 30%. At the same time, as many of our colleagues are on probably, we already are talking to certain governments, among which Ghana and also Cameroon and also Egypt, to try to explain that patients with liver cancer are the workforce of the country, and as such, taking care of those patients and getting access to immunotherapy implies that they will be back to work and will be able to produce for the country and for the economy. So for that, it's a very important matter that really matters to all of us. And with this, I will say that important to join that study. And one more time, I'll show the QR code. Please take a picture of. And I remain, of course, grateful for all the people involved in regard to that, being the all activity at Memorial Sloan Kettering, including our digit team, the genetic, the IT team, in other words, AstraZeneca, Microsoft, as well as Avanade from the UK. So with this, I'll stop sharing my slides, and all three of us, myself on behalf of Dr. Omar, who sadly cannot join us, but at the same time, Dr. Nkozo Ndlovu from Mozambique and Dr. Precious Makundi from Malawi, we're all here to answer any questions you might have. Thank you very much for listening. And just to remind, if any questions, Dr. Nkozo Ndlovu talked to us about patients living with HIV with HCC. Look into the electromagnetic wave frequency in patients living with HIV and HCC clinical trial that already at the last step of approval by the NCI in the United States. Dr. Precious Makundi talked to us about the tumor immune microenvironment and how we hopefully will be able to enhance the better understanding of the immune microenvironment. And of course, the effort that Dr. Omar spoke about, which is on behalf of many colleagues, is to really have a better understanding with regard to which guidelines to use and how can we enhance access to care in regard to Africa. And by the way, I see Dr. Tsika Bukati from Ethiopia is on. Thanks again. I should have quoted well all your great work in regard to make sure that Ethiopia have joined in robustly in that regard to the last study that we did. So I see total quietness, maybe no answer, no questions, but Lavender, let's see if anything in the chat. If not, wondering if any comments on your part. Let's see here. Oh, great. So Dr. Moyo, Nesisa Moyo, can I ask how the tumor microenvironment is contributing to HCC development? Precious, you want to comment on that one first? How the tumor microenvironment is contributing to HCC development and which treatment methodology are in place for that purpose? I don't know if Precious heard me, but again, good. But you want to comment on the first part at least, in regard to microenvironment and how it does contribute to HCC development, which are like the etiologies that you spoke about?
Yes, thank you once again. I can't see the full question, but I'll answer what I have understood to this.
Mhm.
Okay, so generally, the immune system pertaining to response to hepatocellular carcinoma is suppressed. That's why I said that the tumor microenvironment is generally cold. So in my table, if I would be able to project it, I showed that there were signals which were green and the red. The green ones are the ones which lead to the green ones are the ones which lead to the cells to fight the cancers, and the red ones are the one which suppress these signals. So for the cancer to be detected, it needs to produce signals, immune signals, which are picked by dendritic cells, then to the lymph nodes, which lead to the priming and increase of the T cells, which fight the cancers, and these need to enter into the blood vessels in the microenvironment. So the microenvironment itself, because it has the immune cells, the blood vessels, the fibroblasts, the signaling molecules. So if these are working together in tandem, they work to fight put the cancer at bay, of which mainly in the hepatocellular carcinoma, these signals and also these cells and everything are either prevented to enter the cells or generally suppressed.
No, that's great. Thank you much for that, Dr. Makondi. And I'll help you out with the second part. So the second part about which treatment available, and maybe we can comment about what's available to you, for example, at the moment in Malawi in regard to therapy for liver cancer. How much, of course, checkpoint inhibitors you have access to?
Okay, well, for the first line, we are still using the sorafenib, which is a tyrosine kinase inhibitor. We can say it uses the modification of the blood vessels, so it also works in the tumor microenvironment by the modification of the VEGF signals at the blood vessels. Sunitinib is there, but generally the studies using sunitinib have not proven like the beneficial. So we are not quite using it in hepatocellular carcinoma. We are using sorafenib in our setting.
You know, it's very saddening that we are not able to get all of this. And please do remember, everybody, as Dr. Ndlovu showed up in the first slide, the median survival is still in Africa is 3 months. In other words, whoever might get diagnosed by theory today, they will die before Christmas. And for that reason, to be able to really get to those levels where we are now showing 6-year survival is very important to really get access. Proudly, we're very happy that we're doing all that work together, all of us. And the study that I showed you, the QR code, we're going to keep it open. If anyone wants to QR code, I'm happy to share it again. But more importantly, we're going to hopefully close that study by the second week of August, when all of us will be again in Abuja for the AHPBCC, which is probably where we started this in Mombasa last year. So we'll close that study at that time in Abuja, and then we'll hopefully present that data at some big meeting, probably at ASCO. So stay tuned, and hopefully we'll get better access to the immunotherapy. So people like have access to the therapy, and Dr. Makundi and many of us will be able to treat patients as deemed necessary. So with this said, we're at the end of time, but again, number one, big thank for all of you for joining in. And oh, 1 second here. Albert, you have a question. Let me comment before I close it. And you say, this is Dr. Mayamhunga. Just to ask on the GEM study, inclusion-exclusion criteria, did I get it right? It will be take patients and would go through some prior treatment as long as not within 2 weeks from treatment will be not induce boost effectiveness of the therapy. Well, you're right in a way, Albert, and I totally agree with you. But sadly, because of the limited access that we have to any therapy, we're kind of like really would be having a subgroup analysis in regard to those elements being first line or second line. But we felt, and the SCI is supportive that we give access to as many patients as we can, because could be that some patient could have got access to some of the sorafenib possible. We heard that especially from Uganda, but we're trying to make sure that we really get as much analysis as we can, and hopefully this will be a study that will really lead to the approval of that access. The good news, by the way, Albert, and you're like that, the company already committed to us and to the NCI and to Africa that if this really is to be positive, they will keep the instrumentation available in Africa and they will not take it back. So it will be another therapy that's available. Remember, there's no drug to give. It's simply you have the machine and you just like, put it in the mouth for the patient and that will be it. So definitely will be hopefully another opportunity. So anyway, I go back. Thanks so much, Albert, for the question. And I, again, thank you everybody for really joining in. And the big thanks, of course, is to the three presenters. We wish the best for Dr. Omar's mother in Cairo. Big thanks to Dr. Makundi, Precious, who joined us from Malawi. And of course, big thanks and look forward to see you again, Dr. Ndlovu from Mozambique, from Zimbabwe. With this said, again, big thanks to AORTIC for giving that opportunity. And for those of you who are in Abuja this week for the Best of ASCO with AORTIC, please join us. It will be a great delight to see you there. And till then, wish you the best. Thank you very much for joining. Thank you.